Good morning, everyone, and welcome. You are joining us here at Meds Ed, CareOregon's primary care education program, sponsored by the CareOregon Pharmacy team. My name is Paul Carson, training and development specialist, and I'll be your host for this particular installment of Meds Ed this morning. Here's a brief overview of our content here today. We have presenters who will be covering three different areas of didactic content for us. First of all, we're going to talk about things like pathophysiology and how the brain responds to addiction, vulnerabilities of this particular population. We're going to talk about good ways to engage conversation with youth so that we're able to actually create some rapport and be heard instead of the eye rolling, which so often happens. I can say that as the parent of a 15-year-old. And we're going to talk about harm reduction practices as well and school-based health centers and the important role that they play as well. Should have some time towards the end of this as well where we can bring all of our presenters together for a little panel style Q&A. So if you have any questions that come up throughout the agenda, throughout the presentations, or at the very end, if they occur to you, then we can get those all addressed and taken care of. So I think we should go ahead and get started here, and we'll get rolling into our content. These are the broader learning objectives that we'll be using for our CME today. Within each of those separate areas of content from our presenters, though, you'll have different sub-learning objectives as well. So you're going to get a lot of good information that should be very beneficial to you here today. Before I introduce our first presenter, I just want to remind folks a little bit about the idea of this content and the idea of this population. I would encourage all of you to take a moment before we jump in here and remember what things were like when you were an adolescent, in your perspective, whatever time period that might have been in. I know a lot of us at some point in our pasts were exposed to the DARE campaign during the heyday of the say no to drugs emphasis that was being brandied about so much from politicians and from police institutions. That was very, very ubiquitous. Ask yourself if that felt effective to you. Was that something that you thought was a strong deterrence, or did it feel authoritative and something that you did not engage with? We live in a different age now. A lot of things have changed. We have the pervasive advent of social media that youth are very strongly immersed in. We have a lot of different things going on now. When we look at data about substance use disorder in youth, sometimes it can be misleading because we think, oh, look, it's gone down and it's reduced. But we have to remember that some of that data is influenced by school shutdowns and COVID, and there being a smaller potential of interaction between these populations. What we do have to pay attention to is, while sometimes it may seem like the data is looking positive, data involving like deaths by overdose is alarming. And you're going to hear a lot about that today. And we're going to make sure that we try to pay attention and provide resources that help turn that around if we can. There's a lot of variables that are responsible for what we see here, but in addition to social media, we have new variables like sexual orientation and gender identity that are way more influential now in youth populations than they were in the past, at least when some of us were youth. Are more pervasive now, and something that we need to be mindful of in terms of influencing people's openness to looking for escapes, to looking for chances to find meaning. So we need to keep all this stuff in mind. So let's go ahead and bring on our first presenter here today, and let's dive into the content. We're extremely fortunate today to have our first presenter is Dr. Anna Hilde. Dr. Hilde is a graduate of the combined MD and MPH program at OHSU right here in Portland, then left for warmer weather to complete general psychiatry. I can't speak this morning. It's the caffeine. Psychiatry training at the University of Hawaii, where she was a chief resident. It's a lot warmer there, as we all know. And I think we are ready to go. I'm getting a green light on my board. That's great. She came back to Portland in 2016 for her Child and Adolescent Psychiatry Fellowship, where she also served as a chief fellow. She's worked in the community mental health with a focus on youth and substance use disorders in the outpatient, IOP, and residential settings. She currently works for the Confederated Tribes of Grand Ronde, providing outpatient mental health care to tribal members and addiction medicine care at their opiate treatment program Great Circle Recovery. Anna is an affiliate faculty in the OHSU Child and Adolescent Psychiatry and Addiction Medicine departments with involvement in the OHSU Addiction Medicine ECHO and Substance Use and Adolescence. She recently passed her addiction medicine boards and is now board certified in addiction medicine as well as general and child and adolescent psychiatry. Last year, she was honored to be selected to serve as a member of the ASAM Assessment and Treatment Planning Writing Committee of the Adolescent Criteria. It's my great pleasure to introduce you to Dr. Anna Hilde. Dr. Hilde, please take it away, my friend. Thank you.
Thank you so much, Paul. And I am so excited to be here. Good morning, everyone. It's such an honor and privilege to be able to be here presenting on this important topic and to be presenting with two other absolutely amazing co-presenters. So I'm going to jump right into it because there's a lot of information that we're going to be covering. And I'm going to go through a few different things. We're going to look at some data and then really talk about some of the vulnerabilities with adolescents and then get into the neurobiology of substance use disorders and end with some screening. And let's make sure, there we go. I have no financial disclosures. And so just a little bit more of a dive in. These are the learning objectives that I've put together today. So we're going to highlight the data on use trends and access to care for adolescents. We're going to understand how teen brains differ from adult brains. We're going to learn how brain development impacts behavior and risk in adolescents, review the pathophysiology of substance use disorders, recognize risk and protective factors for adolescents, and then become familiar with validated screening tools for adolescent substance use. So what I like to start off with is just talking about, right, the common substances that adolescents use. And we've heard a lot, I think, recently about fentanyl, and which is important because has had a huge impact on our communities and our youth with a number of overdoses. And in the middle picture, you can see an M30 or a blue pill, and that's a counterfeit oxycodone, and so often called an M30 or blue, although many people have transitioned to using powder fentanyl because it's more potent. But really, the most common substances that adolescents are using are alcohol, cannabis, and nicotine. And we've particularly seen pretty significant increases in the use of nicotine because of the modality of vaping. Additionally, there's often use of sedatives like Xanax, and one thing to always be mindful of is that often those that are gotten illicitly can have fentanyl in them as well. And that includes even youth who might be getting ecstasy or MDMA or any kind of powder such as methamphetamine or cocaine can also have fentanyl powder in it. I like to mention as well, and there's a picture here with inhalants, that we often see youth who are experimenting with inhalants, right? Youth are utilizing or using anything they can kind of get their hands on, and inhalants are often an easy thing to access. And so I think it's important to be asking questions about that. And then I also wanted to show, there's a picture of the Coricidin, which is right, cough medicine, often referred to by those that use it as triple Cs, which is really the use of dextromethorphan, which results, when you use it in very high doses, will result in hallucinations. And so often the use of over-the-counter medications in excess is something that youth will do. And so that will include triple Cs as well as Benadryl. So I want to talk a little bit about some of the data trends that we're seeing. Just so you know, this data was pulled from the Monitoring the Future survey, which is a national survey that's funded through the National Institute on Drug Abuse. And it's this annual self-report survey of 8th, 10th, and 12th graders. So this is national data. And what we saw in 2002 was that the percent of adolescents reporting use had increased slightly after a pretty significant decline from 2020 and 2021. And that's really what we saw during COVID, that there was some decline in use, but it seems to be ticking up. From 2017 to 2019, there was a pretty sharp increase in use of marijuana and vaping of nicotine that seemed to level off in 2020. And then, of course, as I mentioned before, alcohol is the most widely used substance and cannabis is the most prevalent illicit drug. So these two graphs, there's the nicotine vaping, and these are, I pulled the data for looking at 30-day prevalence, although there's also 12-month prevalence. But you can see that there's 8th, 10th, and 12th graders, but pretty high levels of 30-day prevalence, particularly in 12th graders, right? Around 20% right now who are vaping. Alcohol, we actually can see sort of a trending down slightly over the years with a bump up and then kind of a bump down, but we're seeing that go back up. And again, that's right around 30%, which is pretty significant. And then this is showing cannabis trends. And again, you can see that for 12th graders in 2020, right, hovering right around 20%. And then there's a graph looking at any illicit drug, and that's other than cannabis. And really saw that trending down over the years. But again, as I'm saying, it seems like we're seeing a little bit of a tick up. So what about Oregon specifically? This data was pulled from SAMHSA, the National Study on Drug Use and Health. And so that's a survey that goes out to all US citizens. And this was just data that was pulled for ages 12 to 17. So it's condensed. So it's not, you know, before it was broken up by 8th, 10th, 12th graders. So this is all together and looking at both 2021 and 2022. And so you can see that, right, the percent of youth in Oregon using marijuana is about 9%, alcohol right around 9%, binge alcohol use about 5%, and then any illicit drug other than cannabis actually pretty high, around, you know, almost around 10%. What we see in Oregon, at least in 21 and 22, is that 12.5% of youth that were ages 12 to 17 had a documented substance use disorder. And that is pretty significantly higher than the national rate of 8.9%. And what we have seen over the years is this kind of stable, fairly stable use of illicit drugs, but we have seen a dramatic rise in overdose deaths among youth, particularly from ages 14 to 18. So I want to jump into that a little bit and talk about adolescent overdose deaths. And this is national data that I'm presenting here, and we'll look at some Oregon specific data. This is pulled from a really good article by Friedman et al. From JAMA in 2022. And so nationally, what we started seeing in about 2020 was that youth really were disproportionately impacted by overdose, and particularly fentanyl. So in 21, fentanyl was identified in 77% of adolescent overdose deaths. And you can see on the graph that's on the top, there's, you know, it shows overdose deaths looking at, you know, benzodiazepines, methamphetamine, cocaine, prescription opiates, heroin, all really pretty steady across the years. And that gray line is illicit fentanyls and synthetics. And you can see how it really skyrocketed starting in 2018, but 2019 to 20 and 21. And then what I really want to highlight is that bottom graph, which is showing how this has disproportionately affected young people of color, particularly American Indian, Alaska Natives, as well as Latinx. So what about in Oregon? Well, this is not a great statistic, but unfortunately, Oregon youth drug deaths and fentanyl-involved deaths are growing 4 times faster than the US as a whole. And so, you know, what we saw from 2018 to 2022, that drug deaths among teens from about 15 to 19 increased by 550%. And in 2022, 100% of those teen overdose deaths involved fentanyl. So you can see this graph, and this was data that was pulled from Centers for Disease Control and Prevention. So you can really see that dramatic increase in 2021 and 2022. And so in 2018, there were about, I think there were 4 overdose deaths. In 2019, there were 5. In 2021, there were 27. And 2022, there were 26. So I like to just think about that. Like that's a classroom of children, right, of youth. And it's really significant, and it's something that we need to be paying attention to. So clearly there are concerns related to youth and substance use. So how is Oregon doing in terms of treatment access? And unfortunately, not very well. So Oregon ranks last in balancing prevalence of youth mental illness and access to care. And we really lack a comprehensive and adequate system of care for youth with substance use disorder, particularly if you're talking about youth who are duly diagnosed. In 2023, the available residential beds for youth ranged from 27 to 36. And that's actually not even their bed capacity, but that was really, there's a little bit higher capacity, but that's related to some workforce shortages. But we can compare that to 2017 when there were 144 beds that people had access to, which even at that point was probably not adequate. We have one withdrawal management facility, but that's part of a residential program and has pretty limited capacity. That's for the whole state. We have no partial hospitalization programs and one in-person intensive outpatient program. There are outpatient providers, but even those are in short supply. And I would say that we really do have issues with accessing medication-assisted treatment for youth. So it's sort of setting the stage that there are things to be concerned about, but that's why we're here today, right? And so we're gonna talk about ways that we can work with and engage with youth and try to change some of these trends. So I want to talk a little bit now about adolescent vulnerability, because they really are particularly vulnerable at their stage of development. Part of it has to do with their actual brain development, and we're going to go into that in a little bit. So the brain is really wired at this time for high reward seeking and risk taking, and with very poor impulse control, which doesn't bode very well. And people that work with teenagers or have teenagers at home can understand this. Substance use impacts cognition and brain development, as well as normal social and emotional development. So any kind of use can really have negative impact. So if we can intervene early, we can really have pretty tremendous long-term impact. There are some pretty serious implications of early substance use. So we know that the risk of developing a substance use disorder is greater for those who initiate use in adolescence versus adulthood. And the data actually goes between about 75% to 90% of adults that are entering treatment for a substance use disorder started using substances before the age of 17. And that risk actually increases for those who initiate or in what we call early adolescence, which is designated as anyone who's under the age of 15. And what some studies have shown is that actually adolescents who drink before the age of 15 are 6 times more likely to abuse alcohol as adults compared to those who waited until age 21. So that's pretty significant. And what we've seen is the earlier onset, particularly those who start using at 11 or younger, that becomes associated with use of more than 2 substances, so often more severe substance use disorders, and a higher proportion of co-occurring disorders. So what is the deal? What is different about the teen brain? And let me tell you, it really is different. And this is a funny cartoon, but again, those who have teenagers at home or work with teenagers, right? This does seem pretty real, like that huge center of disorganization, invincibility, right? The tiny little particle of judgment. So what is happening during adolescence? And when I'm speaking of adolescence in terms of brain development, I'm really talking about from the age of 13 all the way up to about the age of 25. That's when that brain is still really making all these considerable changes. So there's this huge amount of neuron development and pruning. And so what happens is because there's all this active developmental changes, the brain is really more vulnerable to stress. So what is happening really on a deeper level? This is a lovely schematic of a side view of the brain. And so what's happening, you can see the amygdala is tucked down there near the brainstem, and then there's the prefrontal cortex that's right up in the front. And what happens is the amygdala develops much faster than the prefrontal cortex during this period of time. And the amygdala is our emotion center. It's very reactive. And the frontal cortex is what it's not as reactive, right? It controls reasoning. It helps with impulse control and planning. And so, as I said, with this mismatch in development, there's a setting of, right, really high reward seeking and risk taking, very poor impulse control. And what we found even further with further studies is that not only is there this mismatch in the development of these regions, but there actually is the neural pathways between these two regions are not fully developed, and so they can't even send signals to one another. So in addition to that, there's this influence of dopamine. We're going to go into dopamine a bit later, but dopamine is a neurotransmitter that's associated with pleasure, and really it helps, in terms of, gives the feedback for reward seeking, right? So if there's a positive pleasure reward, you get this, this dopamine surge. And what we see is that during adolescence, dopamine is more robust in the brain than at any other time. So what does that mean? What it means that there's actually an increased pleasure that's associated with a reward during adolescence than it would happen at another period of developmental time. So let's say you had that same reward in childhood or in adulthood, it wouldn't actually feel as good as it does in adolescence. On top of that, adolescents have this belief in invincibility, which academically we've termed optimistic bias, but this is actually real. And so, right, optimistic bias is the tendency to overestimate the likelihood of positive events and underestimate the likelihood of negative events. And you can see this cartoon, which I think is a lovely way of drawing it, right? So teens really, right, they're thinking, well, nothing's going to happen to me. It's going to be totally perfect. When in reality, there are all these roadblocks. So there's a lot more risk taking, and this sense of it won't happen to me. And what's a little bit frightening is studies have actually shown that this really does impact understanding of the risk of overdose and the development of a substance use disorder. So beyond that, there's this huge umbrella, right? So we have this developmental stuff, the brain, but we also, right, are in this period of time with psychosocial development. And I like to really think about the theory that Erikson had, because I think it fits really beautifully for the teen years. It's really this idea of identity versus role confusion, right? So this is when young people are starting to individuate, right? Trying to understand, right, who am I? What is my place in the world? So it's really this focus on the self, trying to figure out what you believe in, what you want to become. And so by definition, that's a time of experimentation, which we wanted it to be, right? Because we want people to try things on, see what fits, and then move forward. But it can also lead to some vulnerabilities. In addition, it's really this time where peer relationships become primary. So family sort of is in the background. And so family influence can have less, right, of an impact. And that the peer influence can really have more impact. So that's sort of setting the stage for some of that vulnerability. And now I'm going to kind of go into the neurobiology and talk some about just the substance use disorders and what that looks like in the brain. And I like to set this with just this definition from the American Society of Addiction Medicine, because I think it really lays it out really clearly, and then we'll kind of go into what this all means. So a substance use disorder is a primary chronic disease of brain reward, motivation, memory, and related circuitry. It's characterized by inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. So we know that the first use is actually often voluntary, right? Sometimes experimentation, just trying something. But over time, with continued use, there really becomes a change in brain structure and function. And this impacts the brainstem, the cortex, and the limbic system. And we're going to go into the limbic system, which is really our reward center and a connection to memory and learning. And with those persistent changes over time, it really does impact judgment, decision-making, learning, and memory, and can lead to increased chance of relapse. So what is happening? So all addictive substances activate the mesolimbic dopamine pathway, right? And as I talked about before, dopamine is at the center, right? It's the neurotransmitter that's part of this reward pathway. And what I like to also say is the nucleus accumbens is kind of at the center of it all. So again, you can see this lovely schematic. So what happens? So we experience something rewarding. We have these dopaminergic projections from the ventral tegmental area to the nucleus accumbens, and they release dopamine. And that connects down to our memory kind of centers, which is the hippocampus, and to our emotion centers, which is the amygdala. And the reason for that is because we want these rewarding experiences to be remembered so that they can be repeated in the future. And so the reward pathway, right, provides these positive responses to natural pleasures so people can survive, right? This is all about kind of survival and that primitive process. The problem is that drugs hijack this system both directly and indirectly. And so what happens is there are some substances that people use that will stimulate the release of dopamine directly, such as stimulants, and then others that kind of do that indirectly. And we'll take a look at that. So this is just kind of showing that impact and what happens when somebody uses a substance such as amphetamine and cocaine, and so that directly impact the release of dopamine. And you can see these huge surges of dopamine that occurs. And so those are the pink lines, it's the dopamine. Just the blue and green are the major metabolites of dopamine. And so kind of the time after somebody uses, you can see it kind of tapering off. Nicotine and morphine, right, work with a neurotransmitter, with endorphins for morphine and nicotine acetylcholine. So it's more of an indirect approach, but you still see these surges in dopamine. So again, dopamine sort of plays a role with all the different substances. And this is just to show you so people can have a sense of each of these substances work kind of with an endogenous neurotransmitter system. And I'm not going to go into them all, but again, they all work either directly or indirectly to release dopamine. So what about craving? So we talked about, right, this reward pleasure pathway becomes connected to memory and learning pathways. And over time, right, people, places, and things become associated with substance use, and they can activate that pathway and lead to craving. And so really, it's this repeated activation of the pathways that kind of result in hardwiring habits. And so really, it often becomes this battle between the frontal lobes, right, this motivation, planning, executive function, versus the primitive brain that's focused on pleasure and reward. And so, right, people will have these cues, right, they use in their daily environment, they have a routine, and they will suddenly have these cues that become associated with a drug experience. And these can actually trigger uncontrollable cravings whenever that person is exposed to those cues, even if the drug isn't available. And it can actually happen years into recovery. And there was really some pretty phenomenal research that came out of the University of Pennsylvania that looked just at this, and they used fMRI, and they were looking at the brain activity of patients with stimulant use disorders. And when they would show them these pictures, some were drug stimuli, some kind of a sexual nature, some aversive, some neutral. But they would flash these images on the screen for 33 milliseconds and then immediately follow it with another image to distract the participant and ensure that first picture wasn't registered. And what they found is that participants exhibited brain activity consistent with drug craving, even though the image of the drug stimuli wasn't consciously processed. So it really shows you how powerful that hardwiring becomes. So the brain adapts, right? Because we always want to be in equilibrium. Our brain does, our body does. And so when you have these surges in dopamine with drug use, there's downregulation. So less dopamine gets produced and there are fewer dopamine receptors, right? They get downregulated. And so what you start to see is that there's a decrease in the effect from drugs. And so again, that's when we start to see tolerance, right? The need to use more and more to get that same effect. And then there's some, right, withdrawal that takes place and really feeling less pleasure from activities, or what we sometimes think about as that anhedonia that comes along, right? Because of that pleasure reward pathway. And so there's less dopamine, there's less receptors, so it impacts everything. So I think about that there are these phases of addiction, right? Phase 1 is really pleasure driving the use, and phase 2 is really when people start using to avoid the negative effects. And there's this neuroadaptation, and so decrease in reward and pleasure. There's that increase in the drive to avoid the negative. And what's really important, right, so is that there's activation of the brain stress system, right? The brain becomes so stressed. And so then we have impairment in executive function, and we see people really have challenges with self-regulation, decision-making, and salience, right? Understanding what is important and what is not important. So we're going to move into talking about some risk factors, because, right, one of the things that we can think about, or as we're working with these populations, is understanding what the risk factors are. And we're actually going to talk both about risk factors and protective factors, because both of those are very important. And so, right, this is sort of showing that connection between biology, environment, the substance abuse, and how then it impacts, right, the brain. But it's all tied in together. And what we do know, right, is genetic and epigenetic factors actually account for 46 to 60% of vulnerability, which is a lot. And so some of that we don't have any control over, right? But there are some aspects that we do have control over. And this is where I really like to focus, right, on both the risk and protective factors. And these are adolescent specific risk and protective factors. So what we know is that the risk can include aggressive behavior in childhood, lack of parental supervision, school failure, poor social skills, early substance use, as we talked about earlier, and parent substance use, and particularly in utero exposure, peers who are using, and community poverty. But there are some protective factors: good self-control, parental modeling and support, academic competence, healthy relationships, neighborhood resources, mentors is huge, community and school involvement. So I like to think about these risk and protective factors with this idea of resiliency. So oftentimes, right, there are some risk factors that can't be changed. And so it's really, I think about this teeter-totter, right, where there are the risks and the protective factors. And we're really trying to put more of those protective factors on, or build them actually, as we're working with somebody, so that we can change that, right, the tilt of that teeter-totter. And really what we're doing is we're building resiliency. And this is a strengths-based approach, right? And it's really thinking about not what's wrong with the person you're working with, but really what happened to them and continues to happen to them. And we think about, right, both intrinsic and extrinsic protective factors. And so really often it's about like lack of skills, right? We can think about impulse control, regulating emotions, using reasoning, problem solving, planning, flexibility. Those are all things that can be worked on, and skills can be developed around, right? And then again, that resiliency gets built. And what I really want to point out is relationships. Time and time again in studies, relationships have been found to buffer effects, right, of these risk factors. And even one positive relationship for a young person can make a huge difference in their life. So moving right along, we're going to go into screening, and I'm going to finish up with this. And of course, we want to be screening is really important, right? Because this is the tool that we have to identify adolescents who are using, so we can actually provide some of these targeted interventions, start working them, right, to build those protective factors. I recommend starting at the age of about 11 to 12. I think the earlier, right, the better. Again, not too early, but I do work with some people who started using around even 9 or 10. Screening can be done in a variety of settings, right? It's clearly primary care, and a lot of primary care providers, particularly pediatricians, are already doing this. But even in a behavioral health clinic, as a psychiatrist, what I find my colleagues will often, be screening for anxiety and depression, but won't be screening for substance use. So I think lots of different settings, at least yearly, but depending on where you're at and what setting, you could consider at each visit. And again, routine screening really helps normalize the whole, asking these questions. And then, of course, we want to be using a validated screening tool. So there are 3 screening tools that I like to recommend. There's the S2BI, which is screening to brief intervention. There's the BSTAD, which is brief screener for alcohol, tobacco, alcohol, and drugs. And the CRAFT, which is car, relax, alone, forget, friends, and trouble. All of these are validated to use with youth. They're very brief. They don't take very long. They're self-initiated, which has been shown to be better for adolescents. The S2BI and the BSTAD are actually available through kind of an online portal through the National Institute on Drug Abuse. And let's just we'll go into each of them kind of briefly. So CRAFT has been recommended by the American Academy of Pediatricians for a while now. And so most pediatricians, I think, are using CRAFT. It's actually validated for anybody under the age of 21. So it has 2 different parts. And so you can see, the part A is asking about any use over the past 12 months. And really what they want is number of days, which is shown to be more valid and sensitive. And so they're asking about alcohol use, cannabis use, and then anything else to get high. And then if there is no use, even if there's 0 for the part A, we still want people to be asking the first question of part B, which is, have you ever ridden in a car with someone, driven by someone who was high, including yourself? And then all these questions kind of, ask about, do you ever use to relax? Do you use, alone or by yourself? Do you ever forget things when you're using alcohol? Do family or friends ever tell you should cut down on drinking and using? Have you ever gotten in trouble? And a total of 2 or higher is a positive screen, really indicating further assessment. And so this is just a really nice graph that actually can be used with your clients or patients, So you can do the CRAFT and see what their score is, and you can actually show them, their level of risk for substance use disorder based on their answers. And then this is what the S2BI looks like. Again, that's screening to brief intervention. And really these are meant to be used, as part of a screening, SBIRT, a screening for brief intervention referral to treatment. So again, it's asking about past use in it over a year, but instead of a specific number, it kind of breaks it out into never, once or twice, monthly, weekly, or more. And again, focusing tobacco, alcohol, and marijuana. But if there are yeses, positives to that, then you go on to the bottom part where you ask about, prescription drugs, illegal drugs, inhalants, synthetic drugs. And if somebody has no use, it's really just giving them kind of anticipatory guidance. No referral is indicated. Once or twice, you're going to kind of give them some cessation advice. Again, no referral may be indicated. Monthly use is when you're starting to be concerned, that somebody might have a moderate risk of a substance use disorder, and so you really want to be targeting that. And then weekly or more is really concerning for a severe substance use disorder, and referral would then be indicated. And on these online portals, they actually, you know, and the BSTED is the same thing. If you do it through NIDA, it actually comes up with a recommendation, you know, based on the results. And so the BSTED is all these are very similar. It's again in the past year on how many days, alcohol, tobacco, cannabis use, and then it kind of separates down if you have yeses to those. And again, for somebody who reports 2 or more days, you have a concern for alcohol use disorder. With tobacco, if there are 6 or more days, concern for a nicotine use disorder. And with cannabis, again, 2 or more days, concern for a cannabis use disorder. So, right, it's really important to build this into your routine workflow. I think it's great to combine it with other screening tools. Always thinking about having this welcoming and non-judgmental environment. It's usually more accurate if it's private and not with a family member. And again, I just say this all, motivational interviewing at all times, right? That's what you're doing, and that's going to come after. That's the next set of or the next topic, and so you're going to get more into that. But it's really important. And this is just a summary of what we talked about. I'm not going to read it over just for time, but that is my presentation. Thank you so much.